the chair of this committee. We're not going to ask everyone to introduce themselves because we'll have quite a bit of time then allocated for that. However, I just want to say that we have a guest from the CQC joining us today. If I may let you introduce yourself, please.
Hi, good afternoon, everybody. My name is Taufik. I'm the relationship owner to this organization. So I'm actually here for an engagement session, and so it so turned out that in the middle of the engagement, your meeting came up, and she's kindly invited me over. I thought, okay, yeah, why not?
Thank you.
Thank you.
Thank you. So, just as a reminder that our meeting is held in public today. It is not a public meeting, it's just a meeting held in public. Of course, any members of the public are very welcome to ask questions in the chat if you would like to, or during the conversation, so please do take part. We may be able to answer the question, may not, depending on the nature of the question. The meeting is recorded, but if we can't answer on the spot, then of course we'll provide the answer after the meeting. We are recording the meeting for the purpose of minute taking, as well as for it to be placed, the recording to be uploaded to the website. All committee members, as before we take papers as read. So the presenters, please, when you get to present your papers, do not go through slide by slide, take it as read, highlight only the key areas you would like to bring attention to, and then we'll provide the time for proper discussion. That is where the richness is for us to discuss the items presented. Please, if you can share your own papers and navigate through them, unless help is required, just let us know. So without any further ado, I will start the meeting today. Welcome again to everybody. Rachel, would you like to tell us who has sent their apologies, please?
Okay, I've had apologies from Dr. Frankie Swords, Rebecca Champion, Suzanne Meredith, but Stuart Lines is attending for Public Health, Andy Jacob from Health Watch Suffolk, and Emma Ratzer as well.
PCAC Assembly Chair, yeah?
Yes.
Thank you. Thank you so much, Rachel. Declaration of interest, which is in a pack. Judith, yes, sorry, I can see your hand.
Could I add the apologies of Alex Stewart? I'm here on his behalf.
Thank you, Judith. Thank you. Declaration of interest, as always, this is a published document. The interests are recorded. However, if during the discussion today any additional conflict of interest arises, please record it by putting your hand up and just express what that conflict of interest is. And then Rachel will make a record of that. Rachel, I have noticed that since in the last 2 weeks, actually, this register has been updated. So probably you need to contact governance team because there is a latest version of the register, if that's okay for the next meeting.
Yes, okay, I will do.
Thank you so much. Thank you. Moving on to the minutes from previous meeting and matters arising. So I will take first the accuracy. So any feedback from the committee regarding the accuracy of this meeting minutes? Just points of accuracy, please, if any. Please raise your hand so I can see you. No hands raised. Well done, Rachel. Thank you so much for preparing the minutes. Is lots in there, lots of content, and is very detailed. Much appreciated. It helps with memory and with the discussions. Can I, before we move on to the action log, any matters arising from anyone which may not appear on the agenda today? Any matters arising from the minutes? No, I can't see any hands up. Thank you. Thank you, Rachel. We'll move on to the action log now. Okay, community voices, if I look for them, we have an update today. So I think we've dealt with that. So very possible we can close that action. Paul, I think you're going to update us on lived experience representatives. Do you want to do that now or during your update on the agenda, item number 11?
I can do it as part of the agenda item update. Ali, or it might tie in better with what else I've got to say as well at that point.
Excellent. Thank you. We'll do that. ICS organogram. I think this is an ongoing, so this action will remain open because we're going through currently the change process and the consultation. So this will stay open, correct, Paul?
Yeah, correct.
Good. Thank you. National Patient Survey and Healthwatch reports. Okay. Looks like this action now is complete.
Yes, Aliona, it's Rachel. I've added the forward planners for Healthwatch Norfolk and Healthwatch Suffolk to our committee forward planner.
Excellent, thank you. And we will be circulating the updated version of that very soon, aren't we, Rachel? Of the forward planner.
Yes, yes, we will.
Great, thank you. And the last one is the committee objectives and forward plan. Well, we just talked about it. We are updating it again. So I know it has been circulated recently. However, a few issues came up which we needed to update the forward planner. So as soon as it's done, we will circulate it to the committee. Lovely. I think that's it. Rachel, we'll be able to close that action as soon as we've circulated, if that's okay.
Yes, okay, thank you.
Lovely. Thank you very much indeed. Okay, so I will turn now to Healthwatch. Judith, I know you're there. I know you're deputizing for Alex. When I saw Alex last week, he mentioned, because so far we had one item for you to, with Rachel, to report, that is the patients and professional experience of using digital tools in primary care. However, there was also a report which was shared with a number of stakeholders, a report done with NSFT in conjunction, isn't it, Judith, on serious mental health?
We had a conference. We had a
yes,
conference.
At the conference, and there was a report. And Alex has asked me if that can be presented today. I'm not sure if that message has come to you or not, but I'll leave it for you to present whatever you prepped.
Okay,
so,
I certainly prepped to talk about that event, but
Excellent.
The report itself, I mean, it's an ongoing piece of work that will last for 3 years. So certainly we're not at a position to actually share a final report. We've literally just begun the piece of work. But anyway, I've just got 5 things I'm going to try and update people on quickly. We have lots of work ongoing, but if I can just choose 5 to kind of share with you and highlight with you work that's either finishing or starting or whatever. The first piece of work, and I'm hoping everybody's heard about it, is our 3 hospitals, 3 weeks piece of work, where we spent a week, all of us, pretty much all of us from Healthwatch Norfolk, in each of the acute hospitals. We did the Queen Elizabeth in May, and we went to the James Paget in June, and last week we were at the Norfolk and Norwich. So we've done a week in each of them, and we've gained from those visits very rich feedback. We've got over 500 pieces of feedback from each of them. The report for the Queen Elizabeth has actually, I think, been delivered either in the last, it might have been today or in the last few days. The themes that we are hearing and seeing from those pieces of work are that the care that people say they receive on the whole is very, very good. People say that the professionals that are caring for them on the whole are very kind, very caring and very professional. There are incidents and themes, other things coming, but predominantly the themes that people are less happy about are the environment, particularly, for example, the Queen Elizabeth, the accident and emergency department there. And also, as you probably all imagine, parking is a very favourite thing that people are not very happy about. So the Queen Elizabeth report is done. The other 2 need to still be written, and there will be an overarching report that will cover all 3 and compare and contrast and give some ideas of themes coming from all 3. So that will be published, I think this morning at our AGM, it said in the autumn. So that will come out. So that's a big piece of work. I think it's been really useful for us in raising our profile in those particular, those in the hospitals, because I think there've been mixed awareness of Healthwatch, and particularly for the Norfolk and Norwich. I think we feel it's been a huge success for us to be able to go in there and actually, you know, go to any department, outpatients, accident, emergency, on the wards, and we've been there from first thing in the morning, 9:30 in the morning till 8 o'clock at night, and we've been on shifts and we've been managing. So it's been really useful. So look out for that later in the year. The second thing to report about is our My Views Matter report, which will be published within this next week now. We are very close. We've delayed a bit because of other pieces of work being released. My Views Matter is the year-long piece of work we've been doing when we've been visiting residential care settings for people with learning disability and autism. We've already presented at the Norfolk Safeguarding Adult Board on that and at other meetings within the system. So look out for that one. Now, the event that Aliona has referred to was a conference to kick off a piece of work for NSFT, and it's about carers of people that have serious mental illness. And we were very fortunate to have 3 individuals who are close family members of somebody who has a serious mental illness. And for those of you that were there, and I think there are some people on this meeting that were there, it was an incredibly moving day for us all to hear their stories, and they were very thankful and grateful to have that opportunity to tell their stories to people who in the room have the ability to hopefully bring about change in the way that carers are or aren't listened to and the journey they have. I think there's huge understanding that there are constraints on the system, resources are limited, they understand that, but it's how we can improve things to ensure that the carer's voice is listened to, and that can make a huge difference. From that day, there was a piece of there's a company called Engage Visually, and they created an artwork. The lady's very talented, and that will be shared as well, a kind of pictorially representing what was said at that meeting. And I think that will be shared certainly. And an action plan was devised because everybody who sat on each of the tables was challenged. What can I do to make a difference here? So there is an action plan, and maybe that's what you were referring to, Aliona. She's nodding there. That's good. So that's a really valuable piece of work that we've just started, but that's going to be going on for 3 years. My fourth thing to mention is Major Trauma Centre. We've been asked by NHS England to consult with the public and ask their opinion about whether or not the Norfolk and Norwich Hospital University Hospital should become a major trauma centre. We were able to tack on to our other surveys when we were at the NNN last week this supplementary question. So we've gathered some feedback really early on that, which is good. So that will be continuing. And finally, just to say, we had our AGM this morning live streamed on YouTube. I don't think there were huge numbers watching, but it was there for all to see publicly should they wish. And part of that, at the very end, we announced something called Health Watch Heroes, and this is a Health Watch England initiative because Health Watches are all 10 years old this year, and as part of that we're wanting to celebrate anyone that has been a huge sort of importance or contributed to the work of Health Watch in those 10 years. So this morning we announced the first of, I think there might be 5 or 6 Health Watch Heroes. We're going to announce, I think, one roughly every month leading up to our Health Watch Norfolk live event at the Forum in October. Save the date, please. That's the 5th of October, Thursday, the 5th of October, when we will actually present them with awards. So and today we announced Tony, who is a volunteer helper, helped us with the My Views Matter piece of work, and he came with us as someone with lived experience to actually conduct the enter and view visits for the My Views Matter project. So we were really pleased to announce him as our first Health Watch hero this morning. So that's a kind of whistle-stop tour of some of the work we're up to at the moment, and I'm happy to take questions.
Thank you, Judith. If it's okay with you, yeah, we'll be looking forward to actually getting those reports and sort of scrutinizing them and learning from them, that's for sure. Mark, do you want to ask now, or can we just listen to what Rachel has to say, and then we'll take questions for Health Watch and overall, if that's okay? So Kathy and Mark, if you don't forget to put your hands up again, that would be great. So I will move on to Rachel. Rachel, if you can just introduce yourself, your role, and yeah, we'll have to hear what you're saying. Thank you.
Yeah, sure. So I'm Rachel Green. I'm with Health Watch Norfolk, and I'm the project and research and project manager. I've recently undertaken the second year of a digital tools project looking at access for the public to GP services. I have got a slideshow. I don't know if you want me to put it up or if you'd just like me to give you the headlines. What would be easiest?
Are you able to share it? Just very quickly, yeah.
Yep.
Thank you.
Can you let me know if you can see it?
Yes, I can.
Yeah. Excellent. So we were commissioned by Norfolk and Waveney ICB to conduct a 3-year project looking into digital access to doctors' surgeries. The Year 2 report looks at how patients digitally access primary care. So that's making appointments, attending appointments, ordering prescriptions, and managing long-term health conditions. We're also looking at the NHS app and public awareness and the Norfolk and Waveney shared care record. So we have 3 project outcomes that we were working alongside the ICB with. So outcome 1 is raising awareness of digital tools. Outcome 2 is innovative use of digital tools in primary care. And outcome 3 is increasing public accessibility to information about digital tools. So as part of outcome 1, we're working with the Norfolk Library Service, who have something called a digital health hub that supports people to gain skills to access GP surgery. So this could be through the NHS app or System 1 app or online portals, to give them a bit of confidence on how to set up their NHS logging, for example, and just making sure that it was widely known about. We held an online event for this with GP practice managers and for patient and participation group leads to kind of raise awareness that the service exists. As you can potentially see in the picture, we have Joe Foster Murdoch, who leads on this as part of the Healthy Libraries. No, I've forgotten what the initiative is called. Sorry, it's just gone straight out of my head. But we're also going into GP surgeries to encourage people to sign up to the NHS app to stop wasted prescriptions. For outcome 2, we put together 5 case studies of innovative use of digital tools for 5 GP surgeries. So, for example, Grove Surgery have been using QR codes for signposting and health information instead of physical leaflets since the COVID pandemic. In Trinity Street Surgery, their patient and participation group evaluated how accessible footfall is, mapped it out and looked at the language, so changes were then made. And Feltwell Surgery were part of a hearing loss project where they trialled 3 pieces of assistive technology for patients to evaluate how effective it was in helping communication, and that was for public and professionals. So outcome 3, we're looking at patient and professional knowledge of the NHS app and the shared care record. So what we found in year 1 is that people are aware of the NHS app, although there was initial confusion due to the COVID app, but they're not aware of its full functionality. For example, that there's an abbreviation or a glossary on there that you can potentially book appointments, but that this varies via GP surgery. They're also raising awareness of the shared care record. Aware that the ICB are doing a slow rollout of this, and we wanted to invite members of the public to ask questions to make sure that everything is being covered in the kind of comms material. And we did this through focus groups hosted by patient participation groups again. So looking at our report recommendations, one of them is to encourage more use of the ICB or the ICS to connect with local PPGs, potentially partnering with peer support workers based in primary care and linking them with the digital health hub, so raising awareness of that, linking up with social prescribers and community connectors again to promote the free services of the digital health hub. It was also about encouraging each primary care network to have a digital champion within each GP practice. It was also encouraging primary care networks to share their innovative examples of digital tool use between them, so to get best practice and just to share their learning. It was also to look at all digital innovation is independently evaluated, so focusing on patient experience and satisfaction. So this is something that we've done with one of the case studies. Aylsham Surgery have an automated telephone service called Patient Partner. So we've written a case study about that and also been commissioned separately and independently to undertake an evaluation of the system with members of the public. And then outcome 3 is increasing public accessibility to information about digital tools. So again, it's about feeding back information to patient participation groups, asking their advice and the public's advice on the accessibility of communication materials and digital tools. So that includes the NHS app, how accessible is the NHS app, and making sure that people are aware of what the NHS app could do for them. It's also about creating a straightforward, accessible guide about the NHS app that encourages Norfolk citizens to use it as their digital front door, which is in line with the ICS digital strategy and roadmap. So for year 3, we will continue working with the ICS and the Digital Health Hub, raising awareness of digital tools. We'll also be collecting more examples of innovative use of digital tools in primary care, and assessing the public's awareness of the NHS app and shared care record, and feeding that information back and plugging any gaps in knowledge. So that is essentially, in a nutshell, what I've been working on, and any questions are welcome.
Thanks so much, Rachel. Thank you. So let's take questions in relation to anything Judith said or Rachel. So I'll go back to Mark, then Kathy, and then anybody else, please. Mark.
Thanks, Ali, and thank you, Judith. Thanks, Rachel. Really interesting to see the work and the updates. Particularly focused on the work that you've been doing with the acutes. I think that's really, really positive. So thank you to you for doing that, leading that, coordinating across the patch. I can't wait to see the full learning for it all, but also actually thanks to our acute colleagues who I think have been very open and welcoming. And yeah, I know Healthwatch has a role to be able to do that kind of thing, but actually thank you, because it's been done jointly, hasn't it? Which has been really positive. So 2 questions. Firstly, your work at the NNN last week, what a week to go and do that with the junior doctor strike and the consultant strike that happened last week. Just wondered if there are any immediate snippets relating to any of that, because I think, you know, unfortunately we are predicting that there will be more disruption as we go forward. So it'd just be useful if there's any feedback from patients specifically on that. And ringing in my ears is also the kind of so what point that Aliona rightly and frequently pitches to us. Any early insight for any recommendations that you think you will be making as a part, you know, having done all of the 3 reports, please do let us know early, because we're doing a lot of work right now around work. We've got the national team supporting us around UEC recovery, etc. So if there's any early sight of anything that you think would be helpful for us to know about, please do share early, and I know you will. Thank you.
Thank you, Mark.
Thank you, Mark. Judith, if you do succinct response, but Mark, can you just say who you are? I should have reminded everyone to introduce yourselves, please.
Yeah, my apologies, everyone. I'm Mark Burgess. I'm the Executive Director of Patients and Communities for the Integrated Care Board.
Thank you, Mark. Judith.
Just quickly to say, just echo thanks as well to, as you say, the colleagues or people working at the hospitals, because we were made to feel very welcome, and that makes a huge difference to us coming through the door. And most people knew, not everyone, but most people knew in all departments that we were going to be there, and that really helps as well. So yeah, huge thanks for that. Anything that we came across that was of very immediate and practical concern, we were encouraged and we did report there and then. So, for example, I spent some time in the ambulatory majors, and it was busy. It was very busy, and there were 2 toilets and one was out of action. So that made it even worse. So I reported that instantly and felt assured that the request had gone through to the maintenance. So things of that nature, we were very much encouraged to report, you know, there and then, and felt that we could do that. I don't feel I'm knowledgeable enough, I'm sorry, Mark, to actually give you anything more than that, other than to say what we find, and this is typical of Healthwatch feedback generally, when people leave feedback on our website, they're probably less positive, and they've made that effort to come to our website, and they've got something they're not happy about. So what we receive through our website tends to be more negative. But when we engage with the public face to face, and that can be at GP surgeries, outside the pharmacies, or as this was in the hospitals, the majority of people are actually very satisfied with the care they receive from the individuals providing that care. There are obviously exceptions, that always happens. but the general level in terms of the scores on the doors, because we use a 5-star rating for some of what we do, it's higher than what we receive when we receive it via our website. So it was very positive.
Thanks, Judith.
Thank you. Kathy and then Tracy, that's okay.
Thank you. Hi, everyone. I'm Kathy Armour. I'm a non-executive member. So Mark asked my immediate question, but about recommendations, but I have a secondary one, which is the crossover with Suffolk, Healthwatch Suffolk. Do you follow similar agendas, and how much do you cross over on the recommendations, for example, that you will come up with all of the studies that you've done? Do you naturally share that information and save Suffolk doing the same thing?
Yeah, sure. If we receive feedback for a resident of Suffolk, we share that with Suffolk, so we pass that feedback back to Suffolk. Healthwatch England have national campaigns or national focus topics that we can choose to join in with. So it could be that we are all working on something, or some of us are working on it, but we will all coordinate that work. So anytime we produce a report, that goes to a library at Healthwatch England. So if we're going to start another piece of work, the first thing we'll probably do is look to see, has another Healthwatch done that already? So, for example, I know that within Norfolk there is interest within public health, perhaps to look at vaping in children. And I heard last week there's a report that Blackpool have done on that very topic. So before we ever start any work on that, if we do, the first thing we'll probably do is we'll look to see what else has been done already. So so there is a national library of Healthwatch reports, and we all share. So, and certainly with our neighbours, if it were Cambridge or Lincolnshire, if we receive feedback for their people, we actually send that to them.
Okay, all right, thanks.
Thank you, Tracy.
Yeah, hello, I'm Tracy Williams. I'm the ICB's Clinical Lead for Health Inequalities and Inclusion Health. So really interested in all the work you're doing. It's fantastic, but I'm thinking in respect of the hospital work and those insights that you're gathering and that feedback, really keen to understand when your report is obviously written up and presented, and looking at what are some of the barriers, what are some of the health inequalities, certainly for some key groups, key communities within our system, and is there anything that we can kind of learn from there? And I'm also just thinking about, we're doing some work around insights as well, community voices, and there might be some overlay and some joining up of some of that, which might really give us some really kind of informative, powerful information, I think, to utilise going forward, so we don't have barriers in our services. So that's kind of my first one about that link up, really. And then my second one, in respect of the NHS app and that digitalisation, I think it's really key, and I'm so pleased that there's the work currently taking place to explore the NHS app, but it's just remembering those inclusion health groups, those plus groups, may not have that digital ability without support to actually even download the app, may not have an address, may not have proof of ID to even do it in the first place. So we've got to think about bespoke approaches, I think, for some members of our communities. I'm very keen that we do that. I met with our digital leads today, and they're looking at some work we can do through our own inclusion health work and plus groups as part of an ongoing kind of thing. So very keen to, again, link in with anything that you're doing as well.
Can I just come back on one
of
those?
Of
just to say, Tracy, I
briefly.
wholeheartedly agree about the barriers. Each area we went into, we did have a specific questionnaire for, and within each of those there were questions about, were there any barriers that, before you were able to seek the help? And certainly in accident and emergency, some of the responses there are quite telling in terms of the journey people had, whether they went to their GP or not to their GP, or whether they got sent straight from there, whether they went GP 111. And so we've got some interesting, stories to tell there. But certainly the issue about barriers to contacting those health services prior to going to A&E, that's certainly part of what we've been asking questions about. So I just feel it's a little bit early for me to be saying what any of the findings are, to be fair, but they will come.
Thank you, Judith. Paul.
Thanks, Aliona. So just two things from me. One is to say thank you to everybody at Healthwatch Norfolk for this incredible amount of work that's been done in these key areas and projects. It's really important to us from a comms and engagement perspective. So I head up the comms and engagement team at the ICB, just for people that don't know who I am at the meeting. But I think, you know, it kind of links to what Tracy just said about actually, you know, vulnerable groups, inclusion health groups, and those that might not necessarily be able to either access digital means and methods of engaging and transacting with the NHS. But ultimately, what we do also have to remember is that people that actually can and do actually also sometimes have trouble doing this. So a couple of weeks ago, linked to your project, Rachel, I was speaking quite close with Fiona Tyus from Healthwatch Norfolk about a number of individuals from a practice that actually want to transact digitally and want to use the NHS app, but are actually finding it really difficult to do so. So I think it's really welcoming that we've got this big project underway, but also just to reiterate that as an example of where this feedback is coming in, actually we are reaching out to people to try and enable us to actually create change and do these things right. So for example, speaking with a number of individuals at this particular practice, our digital team's been able to go out to that practice and those individuals, and actually now they're fairly confident using the NHS app. So that's a really good way of actually this important, a really easy, quick way of showing that some of this important work that's done actually is the so what test. But it's about reaching out and making sure that we do take these recommendations and actions on board. And that for me is the really crucial thing. So it's just an A, thank you, and a B, recognising that, you know, there are certain pockets of targeted work that are happening as a result of these really important projects taking place.
I'm very pleased to hear that, Paul. Thank you. There's no point to ask people a question if we're not prepared to learn from it and do something different. Otherwise, we're just going to insult people by asking the question. So it is very important that we actually act on what we hear. I can't see any more hands up, but Rachel, I'll just come back to you in relation to is an observation and an encouragement type comment. The first one, the portable loop, which just put us in an innovative tool. It isn't. I'm really sorry to disappoint you all. It is a requirement of the DA Act. It should have been there for ages, and it shouldn't be seen as something special. So if our medical practices don't have that, they need a reminder that they must provide that is not a choice. So I think we need to remember accessibility is important, and the provision, legal provision as the minimum, if nothing else, is very important too. And the other one is just to say, please, can we make sure we link to the digital strategy team? Mark, I'm sure you'll be able to tell Rachel who the right contacts are, but we just need to make sure we connect the work of Healthwatch in this area together with our own team. The digital strategy is in place. There's lots of work happening. We just need to make sure we're connected at the system level. And also I'll connect you back to Paul to say, you know, there is a way of promoting the app and sort of empowering people. So again, the ICB should be able to support it, all of that. So please, can we just make sure that we are all connecting and taking the learning forwards? Thank you so much. Okay, but well done indeed for all the work. Can you pass our thanks to everyone at Healthwatch and for everything, and we'll look forward to the next update on those reports. Thank you. Okay, with my apology to Rebecca, we're going to move on to the next item, and that is a spotlight on children and young people. Rebecca, I will let you introduce the item. Introduce yourself, please, first. And if you're happy to share your slides, please, and just give us a summary. But take it that we read it in the first place. Thank you.
So, for those that don't know me, I'm Rebecca Hume. I'm the Director for Children, Babies, Children, Young People and Maternity, and I'm a joint post between the ICB and Norfolk Children's Services. And that's in recognition of the integrated way we need to work to make sure that we're meeting the needs of our children and young people, and that we work in a really early intervention and a prevention way with that group. So just a quick introduction. I've highlighted on the slides that I shared today just some of the work that's included just for babies, children, young people in the Joint Forward Plan. That doesn't include the work around mental health that we're doing, and there's an entire section that we're part of in the Joint Forward Plan there. We're doing lots of work in school and community zones with our local authority colleagues around safeguarding, looked after children, and obviously then there's also the maternity work that we're doing. In all of those work, we do as much as we can to co-produce and engage with our target audience. So we work alongside youth advisory boards, the SEND forum, with Children in Care Council and parent carer forums. Maternity have the maternity and neonatal voices partnerships that we also engage with, and we endeavour always to have the voice of children, young people, families and carers in everything that we're doing. Mostly we have them on all of our sort of working groups include a carer, or we try and get children's views in as part of that. And so there's many examples of that, and I'm happy to share them with people, but I could take up the whole meeting talking about babies, children, young people. So I will try really hard to target what we're doing. So my particular role is around, we're looking at transformation, integration and commissioning, and it's very much about integration that a lot of the work that we're doing. Because as I've said before, we can't do our deliver for children, young people and families if we don't do that. So I'll just quickly share and go through and highlight some of the work that we're doing on the slides. It was difficult to narrow down, if I'm honest, about what to bring to you today. So I thought it would be helpful to just highlight some of the programs of work. Sorry, I'm struggling to get my screen shown. Can you see that?
Yes, thank you.
Lovely, thank you. Okay, so it's just to put it in context, and I think people that it can often be because of the problems we have in the system. You've just talked about the work you've done in hospitals and some of the other engagement work we do. It can very much be focused on adults and older people, and we do have nearly 300,000 individuals between 0 and 25 years, and they do make up 25% of our Norfolk and Waveney population, and that's really important to remember. They're a big cohort, and if we're talking about being involved in early intervention and prevention, where else should we start than with families and children? So, and that should be from preconception onwards if we're to do to make a real difference. We've got, talking about working in a collaborative way, we've got 500 state-funded schools and nursery and education settings in the system, and around 1,400 young children in care. All very significant numbers when you're looking at this. And we have 3.8% of our school population are estimated to have social, emotional, mental health needs. And we know that that's not based on necessarily a disease process. Children's mental health is very much affected by the environment that they're in, their socioeconomic status. And again, that comes back to where we need to work really closely with families and with our partners. And we're also an outlier in smoking at time of delivery in Norfolk and Waveney, which is a big issue. If we're going to get our families and our children to have their best start in life, we know what an impact that has on outcomes. So just to mention Flourish, because I wouldn't get away with it without mentioning it, we do have an outcome framework that we work to for children and young people. It's a really useful framework that we share across the entire system. So it's not just a health framework. This is anybody working with children, young people and families. This is what we're trying to achieve. And obviously it's an acronym and it's on the slide and I'll let you look through it. We're all signed up as a system to deliver those outcomes and to support our children and young people to flourish. So I'll advertise this whenever I can. I think it's really important that we have that flourish ambition at the front of our minds when we're thinking about children and young people. And again, just to come back to this, recognising that the health of children and young people is determined by far more than healthcare. So we try not to talk about our children as patients. They're part of our population. In fact, I try not to use the word patient at all. We're talking about individuals and their holistic needs. So it is their outcomes are determined by education, housing, and stable and loving family life, and the healthy environment. So we really, it comes back again to that need to talk to families, hear their voices, but also work with system partners. Can't do it in isolation. And recognising that first 1,001 days of a child's life being critical. This is nothing new. We're not trying to achieve anything new. The evidence is there as to the difference we need to make. We just now need to work together collectively and bring our collective resource together and focus on that first 1,001 days, because it will pay dividends throughout the whole life course if we can get that right. And this just talks about our ambition. So some of the work that we're doing, I've highlighted here. These are the things that are in the Joint Forward Plan. The Start for Life and Family Hubs, that's very much a joint piece of work. That's being led by Children's Services, but it has input from all system partners, VCSE and community providers and health. And you'll see there that it does really cover that very early part of life. So there's a real focus on perinatal mental health and parent-infant relationships, early language and home learning environment, all those things that really get the best start of life for families. And this is done very much in co-production. There are children, young people involved in most of those groups, either actually actively coming along, or they are we use them as a reference group, because often they would prefer to give opinions on things rather than actually being present in all the meetings, which can be quite boring. They tell us they don't want to hear all the stuff around governance. They just want to hear what about the outcomes and how you're going to meet our needs. And again, we have parent carers in those groups. Obviously, there's lots of evidence there as to why we're doing this work around family hubs and Start for Life, and we are really measuring that work. It's a nationally funded programme, but it is really been done in a co-produced way across Norfolk and Waveney. This is the elements of the Core 20+5. Now, initially the Core 20+5 was just for adults. We were really pleased to see that actually a children's version came out, because it wasn't relevant to that 25% of our population that the initial bit was targeted at. So you won't be surprised to see some long-term conditions here: asthma, diabetes, epilepsy, oral health. Healthwatch have done loads of work, and most of what many of your calls and inquiries from the public around oral health, and for children, young people, it's a massive issue for us, access to dentistry within Norfolk and Waveney, and obviously mental health on there as well. So and obviously we know why those are a priority. We're really interested in the next bit that Tracy's going to raise on the agenda, where we're looking at the plus elements, and we certainly have strong views in children, young people, what that plus element should be. But there's projects being driven across for all of those. We're again, asthma and respiratory problems are a big problem in Norfolk and Waveney. We're again high prevalence. So part of that is environmental. It's not all to do with children and underlying health, but of course we have the smoking at time of delivery as being a big issue. So there is likely to be a join up between those things. So we really do have to start tackling things very early on, and we're working with children and families on all of those areas of long-term conditions. And occupational therapy, we're piloting a piece of work. We were very lucky to get some funding for integration work, and that was very much driven by feedback from families about how complex it was to access services. We were finding that there was duplication across the system and a really complicated offer. So that was why occupational therapy was chosen, because it's present in pretty much all parts of the system, and yet we didn't have a joined up approach around delivery of services or meeting need. So there were many gaps and much duplication in that area. And I just thought I'd highlight some of our key partners. I've only touched on the work that children, this is only the stuff that's in the long-term plan. Everything that's happening in every other part of the system for adults will also be happening in the children's space. Within the ICB, we're a very small team. We do, as I say, we have to do the transformation element, the commissioning element, performance and integration. And that's a huge piece of work for us to deliver. And also to try and work at place level. So it's just a plea for everybody: when you are doing your thinking, please also think children, because we can't be everywhere, but children, young people are. So we just need everyone to think children, young people and families when they're doing their planning. So I just thought I'd also demonstrate the links to all the other ambitions of the Joint Forward Plan. The only one that doesn't impact on children, young people and families is that transforming care in later life. All of the other areas, we have to have some presence to make sure that children, young people and families are represented, because all of those areas impact on our children as well as on our adults within Norfolk and Waveney. And then just really to highlight some of our statutory duties within the system as well. I'm not going to go into detail of those, but there are significant statutory duties that we also have to be aware of when we're thinking about children and families. So It's again quite a huge agenda. All of those, every single one of those is an integrated approach. There's not one part of those statutory duties that we deliver on our own. They're all done in partnership with the wider system. So I'll leave it at that and stop sharing. And I'm happy to take questions or comments from people in the meeting.
Thank you so much, Rebecca. Rebecca, can I start the questions? You talked about engagement of children and young people, and you had on the key partners, families are listed. How do you engage families in this work?
So we'll always be looking in all of the areas that we do work, we'll be looking for experts by experience. So if we're doing work around respiratory, we'll be looking for families who have children that might attend hospital frequently to gain their views. If we're working with special educational needs and disabilities, we have our parent carer forums that we engage with, and they are very present in our meetings. That's in Norfolk and Suffolk. So we've got Suffolk Parent Carer Forum and we've got Family Voice in Norfolk. But we'll also do a lot of work where if we have inquiries from families, so if somebody comes from PALS or comes to us with a complaint, we'll ring them back. We don't very often just respond. We actually speak to the individuals. So much of our understanding comes from working with people who contact us to try and understand where the gaps are and how they might support us in our learning. And the same where we have safeguarding practice. So if we're working with safeguarding, even in those reviews, we try and get the voice of families and children. So we would go out to families and wider family members if we've got any particular problematic areas. So many approaches that we take, Aliona.
Good. Thanks so much, Rebecca. Thank you. Do you have an indication of the timescale for some of the improvements you highlighted, the work which is underway? Any ideas when we may be seeing the difference and how we're going to know the difference is made?
So we use the Flourish outcome framework to come up with some measures. So we're trying to have system-wide measures, because obviously if we put improvements in one place for children and people, you don't always see the evidence in that particular space. So even things like school exclusions or days missed from school through ill health, those kind of things are being captured as a system. So we do have a system approach to that. I think it's going to be one of those things that actually we won't necessarily get if you're a family who've experienced the gaps that some of our families have for quite some time, I don't think we're going to change their views of how our services are being delivered, because they've experienced poor access and perhaps not the best outcomes. And once you have that mindset, it's really difficult to change people's experience. What we should begin to see is less people coming to us at describing gaps. And that will be telling. We should see numbers of people smoking at time of delivery coming down. We're hoping to see less admissions for asthma as we get more of the programmes up and running around respiratory illnesses, and the same with epilepsy. More people will have access to a specialist nurse, which not all families do at the moment. And of course, oral health. That's going to be something that we'll have to measure over years, because much of the damage is done with our young people. We've got to recover for those that already have problems with their oral health, but we now need to start to see that reducing in the earlier years. So I don't see us seeing many results from this, Aliona, if I'm honest, for probably about 10 to 15 years before we're going to begin to really see some of the outcomes. Because children, if you miss those first 1,001 days, you're still picking up the problems in the 10 to 15-year-olds and up to 18-year-olds for years to come. So I think we'll see early results from some of the asthma work quite quickly. I think the OT work will begin to see evidence of that. We've had some work around speech and language therapy that's beginning to really show results. We're beginning to see less need in that space, but it is an ongoing programme of work.
Thank you, Rebecca. I think it will be good in a number of months' time for us to, where the work actually is more measurable at shorter term. It will be good for us to see what the impact is and the difference we're making. So yeah, I'll let you inform us when we think we've done enough progress to be able to actually see that. Is that okay?
Definitely. Yep.
Thank you. Tracy. and then Judith.
Yeah, thank you, Rebecca. Just aware of all the huge depth of work going on. So, you know, aside to the 1001 days, we still need to think about the whole life course, don't we? I think, and certainly that kind of those wider determinants of health, the housing conditions, and all those things, the socioeconomic elements that kind of affect, you know, both our babies, our children, and our young people as they go into their adult life. So, I think, and I know. I want to just notice that Paula put in the chat that kind of crucial link, I think, at place with our health and wellbeing partnerships. So where our communities, where our families or our people are living, it's vitally important that as we develop a wider kind of approach to addressing inequalities generally, that we do that joined up together. So I think that kind of wider determinant elements is absolutely crucial, really, for those longer term improved health outcomes. And I know that's all within in consideration of all the work that your teams are doing, Rebecca.
Thank you, Tracy.
Thanks, Tracy. That's really helpful.
Thank you. Judith?
I just wanted to pick up on the oral health dentistry issue. Rebecca's absolutely right. It's more than half the feedback we generally receive day to day about the difficulties in accessing NHS dentistry. And this is a question that maybe it's not for you, Rebecca. It might be for somebody else in this meeting, and maybe the person who can answer it's not here. I don't know. But I'm kind of, in the knowledge that this is a public meeting or in public, want to ask the question on behalf of the public. Now that dentistry falls within the remit of the ICB, and it's very early days, I appreciate that too, so it may be too soon to say, but is somebody on this meeting that's able to at least say some of the things for public knowledge that the ICB is looking to do to try and improve that situation, notwithstanding we all understand that what is really needed is a new national contract?
Thank you, Judith. I was expecting Mark to put his hand up, and he did. Thank you, Mark.
That's good. Yeah, it's yes, we've inherited a very challenging position, haven't we, around dentistry, Judith? And you mentioned the national contract, absolutely. So it will be better at a future meeting to come back with more detail. Sadie Parker can come along. However, just to acknowledge that, yes, we are looking very quickly at what could we do as an ICB, particularly with regard to access to urgent emergency dental care. And we've actually made some proposals that have been signed off at various boards and committees around, something that we can get off the ground quite quickly. The bottom line is one of the main limiting factors is workforce, as it is in so many areas. So, we're not going to solve this overnight, but actually it might be quite a good subject to come back to a future patient communities committee to update on our immediate plans, because we have moved quite quickly on this, Judith, because as Rebecca has highlighted, for children but also for adults, we are a long way from where we need to be around industry.
Thank you, Mark.
Can I just reflect on that as well? And obviously in the children and young people space, we need to be working very closely with public health around prevention. Oral hygiene is very much more prevalent in our areas of highest deprivation, and obviously it's impacted as well by access to the right sort of food, and that's often due to economic circumstances as well as education. So there's a lot of work that needs to be done in that space around prevention, because we will still be facing these problems in the years to come if we don't also tackle that preventative space. So for children and young people, we really need to have a bit of a focus on a public health approach to this, and particularly working with schools. So schools are a route in for an awful lot of our work.
Thank you, Rebecca. I'm just going to suggest for Rachel, for the forward planning tool, please can you add that very soon, maybe within the next meeting or meeting after next, so for us to have an update, please. I have also would like to comment, and I don't know if that's what Paul just did, but I have already started seeing some promotion within LinkedIn on education about dentistry and so on. Paul, I think is something happening from comms. I don't know how, not everyone is on LinkedIn, and I'm wondering what other platforms are being used to actually sort of encourage population to look after their oral health.
Yeah, I can comment on that quite quickly, Aliona. So we are using social media extensively. So Facebook, Twitter, Instagram, Snapchat. We're also using TikTok to get some of this information out. And yes, as Mark said and everybody else, it's very early days. with dentistry, but we are updating that information based on feedback that we are getting, and there will be another update going on there later this week. But we're kind of trying to look at it from both an urgent dental treatment issue, trying to get the information out, as well as starting to look at the general more preventative campaign work, which we're liaising closely with colleagues at Norfolk County Council and Suffolk County Council public health teams to kickstart that off.
Thank you, Paul. Rebecca, in chat, there is a question. I don't know if you spotted just now. It came from me, but actually the question is from our guest. So
are you referring to the hubs work?
Yeah, the show start, and there's similarities to the hubs work. That's right.
There are some similarities, but this is much more based around professionals working together. The hub work. So in many cases, they're virtual hubs, and it is a system approach rather than Sure Start, which was much more focused on early years in children's services. This is much more of a holistic approach, and actually it's really encouraging that they are really focusing on the best start for life, which I think is quite different to the some of the Sure Start programs. So there are similarities, and we get that a lot, that people say, well, is it not just Sure Start? I think it's learning from what worked well and building on that to make a really system approach within the hubs.
Okay. Thank you.
Thank you. I can't see any more hands up. Anybody else with any more questions for Rebecca, please? Rebecca, I can't see any hands up. So thanks so much for updating us today. We will look forward to hear, not in the very far future, on those items where you are able to make progress, and then of course we'll see what happens in a year or two or three when the sort of the longer term or 15 years, as you're saying, if we're still around, some of us. But let's measure it much sooner, what we can measure, and I'm sure we'll look with curiosity to see what's happening. Rebecca, thank you so much, and thank you to your team. Thank you. I will move on to Tracy. Tracy, Core 20+5 improvements framework, please, if you can take us through that, please.
Yeah, I'll see if I can share the slides. If not, I'll ask Rachel to do that, but hopefully I can share the ones. I put them together quite last minute. Is that coming up at the moment? Can everybody see that?
Yes, we can.
Okay, so yes, so I'm Tracy Williams. I'm the ICB's clinical lead for health inequalities and inclusion health, and today I just want to go through some work we've been doing in respect of our plus groups. So as an introduction, really, Norfolk Waveney ICB, through the Joint Forward Plan, sets out the rationale for why tackling health inequalities is very important. The ICB has a legal duty to tackle health inequalities, and our ambitions for improvement in relation to population health management and reducing inequalities and supporting prevention. And over the next few months, we are committed to developing a Norfolk and Waveney health inequalities strategy to deliver the Core 20+5 approach. Let me just move on to the next slide. Okay, so I'm hoping that you're all very familiar with the Core 20+5 tackling health inequalities improvement framework. Rebecca just talked about the children young persons approach. So we do have an adults approach, and we have a children's young persons approach. So the framework is designed to contribute to ongoing work already in the long-term plan to improve on those health inequalities. And the Core 20+5 framework sits within 5 clinical areas for children, young people, and 5 clinical areas for adults. The Core 20 are the most deprived 20% of our population, according to the Index of Multiple Deprivation. And then we have what are known as our plus groups. So our plus groups are those additional groups of people living across Norfolk and Waveney who may not be part of the Core 20 population, but are known to have experienced perhaps difficulties in accessing healthcare, and as a consequence of that difficulties in perhaps experience of accessing and being able to access that healthcare, their health outcomes are often much poorer. And so we aim to address those inequalities as much as we can. So in order to undertake the piece of work in defining what our plus groups are for Norfolk and Waveney, there is some NHS guidance that we followed. So the guidance is that plus groups are at an increased risk of health inequalities according to this guidance, And there is some definition of what plus groups might reasonably be expected to be included. So these are some of our ethnic minority communities, people with a learning disability and autistic people, other groups that may share protective characteristics under the 2010 Equality Act, groups that experience social exclusion, known as inclusion health groups, and our coastal communities, and where there may be small areas of high deprivation hidden among relative affluence, and people with multiple kind of comorbidities that causes vast inequalities. And special consideration should also be given for inclusion health groups in young children as well, young carers, looked after children, our care leavers, and those in contact with the criminal justice system. And there's just a definition there to help you in respect of our inclusion health groups. Just move on to the next slide. Okay. So how did we go about this? So identifying our plus groups in Norfolk and Waveney, we used the three main sources of information. One of those was the guidance that NHS England had set for us. And actually we looked at lots of the national data sets that are available. Fingertips data is an example of that. We used information prepared by Norfolk County Council's public health colleagues with information on the estimated numbers and experience of the proposed plus groups that we had, and looked at some of the local needs assessments on the Joint Strategic Needs Assessment, which you'll find that data pack is part of the papers. The Suffolk Director of Public Health's Annual Report 2022 already focused on Core 20 plus, so Suffolk had done a lot of work and identifying their plus groups, and that was attributed to Waveney for us. So again, there's a pack in the paper which you can see which explains that. We took great care to ensure that the chosen plus groups, Norfolk and Waveney, were both aligned with the ones that had been chosen for Suffolk for our Waveney area. So that's the data that we looked at in order to kind of get to where we got. We had some overarching governance, so we had the kind of the data packs that were taken through a discussion paper to the Health Inequalities Oversight Group. That was at the end of May, with the list established, and then the final list was approved by the Population Health and Inequalities Board on the 20th of June. And we're bringing this here to you today for further information. Without saying, with this, the inclusion health groups that we've chosen are ones that I said is according to data and according to national guidance. So for Norfolk and Waveney, the groups include our inclusion health groups, which is those people experiencing homelessness that may have drug and alcohol dependence, our asylum seekers and vulnerable migrants, our gypsy Roma traveller communities, sex workers, people in contact with the justice system, and victims of modern slavery and other social excluded groups. And that's an all age approach for that plus group. So we have people living with a learning disability and autistic people, and that's all age. We have people from minority or ethnic groups, such as our Eastern European communities, our Black and Asian communities, and again, that's an all age approach. Our coastal and rural communities, where there are areas of deprivation and where we do find those pockets of hidden deprivation amongst that relative affluence, and that's all age. Our young carers and looked after children, our care leavers, and that's specifically for our children and young people. And then in addition to that, so we didn't really want to miss any selected populations that were at more multiple disadvantages. We wanted to have the scope for any selected population at a locality, at a PCN, at a health and wellbeing partnership level, if identified from data that they were experience additional health inequalities and difficulties in accessing care, and outcomes were not so good as a result of that. Some of the challenges that we encountered, or will encounter, I think, as we scope this work out, data and information for our plus groups are often not timely and complete. So we need to kind of see what the quantity of the population size and what meaningful comparisons we can make. So we'll be exploring how we can do this, looking at the joint needs assessments for both Norfolk and for Suffolk, and actually this will ongoingly be monitored through our Health Inequalities Oversight Group of work, and we'll look to have deep dives as well into groups going forwards. We know certainly with our workforce, their kind of knowledge and skills and awareness raising in respect of our inclusion health groups, our plus groups, sometimes can be a little bit challenging in those communities. So we'll do some work that builds into our health inequality strategy as part of the ambition of the joint forward plan. And we want to align this with the timescales aligned to the strategy development, which is going to be completed by March 2024. We know there'll be resource implications, so there will be requirements, and we're wanting to kind of look at what that kind of the programs of work might need to and the resource to support that. And a future paper will be presented to EMT to outline a case for change to support both the implementation of the health inequality strategy, and also including that will be our plus groups. So finally, our next steps, just moving on to my last slide. So the next steps really within this approach, there are care opportunities obviously to address some of the inequalities encountered by not only our core 20 plus communities, but our additional groups that are disadvantaged. So we will need to do some further work to identify gaps in services, and recommendations of next steps that we'll certainly bring to this group and all the other kind of governance structures we have in place. We want to align that with some of the other work that's taking place in the system through the community voices. We want to co-produce and work with communities. We want to develop the health inequality strategy as part of our joint forward plan ambition, and that will take place over the coming months to March 24. We'll have a governance oversight of that. And what we really want to do is, as a starting point, is to take a stock take of existing programmes of work, see what work is underway in respect of plus groups, see where there might be gaps and what we need to do and how we coordinate that together. And we want to assess that information, and we hope to take a summary report of that to the Health Inequalities Oversight Group in October. So that's my slides finished. So I'm very happy to take any questions. And there are other people on the call that's been involved in some of this work as well. I hope that's helpful.
Thank you, Tracy. Do we have any questions? Yes, Paula, please.
Thank you, Aliona. Just to say, Paula Boyce, Great Yarmouth Borough Council, here to represent the 8 Health and Wellbeing Partnerships. Tracy, music to my ears. Thank you very much indeed. Really, really grateful. Being on in a coastal community, I know I share with Waveney and Kings Lynn that a multitude of complex issues which all sort of fit into this arena. So that's great. I'm also really pleased to hear that the Health Inequality Oversight Group has been re-established, and I just ask that the district councils get a seat on that again. We were there in 2022, and my apologies if I didn't realise it had already been re-established. So if that could be looked at, please. Thank you.
Yes, no, absolutely. I believe you are there, but I can't recollect who's there from your district colleagues' representation. But we'll make sure that the right people are there. And certainly, we have paused for the summer. We didn't have a meeting last week because of the restructuring announcements, but we certainly will be resuming in September, and we'll ensure that we have the right district council representation there. So thank you, Paula.
Thank you, Kathy.
Thank you, Tracy. I just wondered, because you could only have 5, are there groups that you really wanted to include, but that you haven't been able to include, or have you managed to squeeze them in using the existing criteria?
I don't think we only have got 5. I think we've got the 5 that have kind of been recommended, plus where we looked at the data packs. The right. 5 element is the 5 clinical areas, and we've got 5 clinical areas for children, the young people, and 5 for adults. I think when you look at our plus groups, we've kind of enabled there to be kind of flexibility, I think, and certainly when we look at, we have that flexibility both at a real locality kind of place, neighbourhood, PCN level. I think that gives us the flexibility so that nobody's left behind. And I think what we mustn't forget that many other kind of groups that are disadvantaged, I absolutely know that and struggle. There are other kind of programs and transformation areas of work that those people are picked up anyway, and many communities will hopefully be picked up in our core 20 areas as well. So I'm hoping that we haven't missed any, but certainly if we recognise that we are, we absolutely want to include those going forwards. I think we've got some scope to do that. I think our methodology hasn't kind of put us in a corner, so to speak.
Yeah. Okay, lovely. Thank you.
Thank you for providing that reassurance, Tracy. Tracy, thinking about the next stage and some of the challenges you identified, is there anything you would like in terms of support from the members of this committee, please?
I think it's support as we go through and, as I said, do our kind of stock take and look at where we have gaps and what capacity we might be needed in the case for change. I think support from this committee for that would be really welcome. I don't know if Mark wants to say a little bit more about that as our senior responsible executive director for health inequalities.
Other than to just echo that comment, really, I think, you know, we've got real challenges, haven't we, across the system, real challenges around finances, but I think everyone on this call appreciates how important this agenda is, and prevention, and, you know, really focusing our work on tackling inequality. So yeah, just in support of Tracy, really welcome general support to this from committee members, please.
Thank you. And Tracy, yes, if you do stumble over things, do highlight it, please, so then we know what we're supporting with. But well done, and good luck in the next chapter on that, and we'll look forward to hear how things are going. Thank you indeed. And I am very pleased that Mark is sitting here. He can also update us on the Population Health and Equalities Board doings. I think the board met now officially. And yeah.
Yeah, I'll just give a quick verbal update. I'll take the paper as read, and obviously Frankie's given apologies and Suzanne, so I'm presenting this on their behalf. But just a couple of things I'd be keen to stress to committee members. Firstly, the three areas of assurance as highlighted and updates in the report around the terms of reference, that the plus group identification is just shared by Tracy, and also the work that we're doing around the maturity matrix and work with region on that, just so information in that. I think there is one action that we need to take, and it escalates the item around patient representation at the Population Health Management and Inequalities Board. And if you're happy, Chair, I'd propose that we capture that as an action to link in with the work that we're doing around patient representation more generally for this committee as well as that. So perhaps that's for you and I, Paul, to pick up as an action to make sure that we also have appropriate representation on that board, if that's
great.
okay.
Yes, please. Yes, please. Thank you. And we'll have an update, see how you're getting on when we get them. Yep. Thank you. Okay. Thank you, Mark. Any questions for Mark? No, you got away lightly, Mark, this time.
I did, didn't
I? Okay, so moving on, we're going to look now, running 10 minutes late, apologies for that, or almost 10 minutes, discharge transformation program update. I think we received an apology from Catherine, Mark, but I think we have. Who do we have?
We do. Ross has joined us. So this was a very last minute. So unfortunately, Catherine's unable to join today. But Ross, with very short notice, has very, very kindly agreed to come in and present this item, just to give committee members an update on where we are around discharge. Obviously, it's a very important area for us in supporting the patients, not just in our acute hospitals, but also in community units, and support them on their onward journey following a stay in acute care. So thank you, Ross, for coming today in place of Catherine, but over to you.
Thank you, Mark. Is it helpful, Chair, if I put the slides up? Oh, Rachel's doing that for me. Look, fantastic, even better. So I haven't got to drive. Rachel, if I probably would take you down to what would be slide 6 first, if that's all right. So I'm going to take them slightly out of order, if that's okay. And I promise not to talk for too long.
Rose, if you take it that we read the papers, yes, so give us the highlights.
I will just give you the highlights. I guess that's why I'm probably taking you to this one first. So I think for me, it's just helping to contextualise where the discharge work sits in terms of our UEC priorities for this year. And apologies, that's quite small. I think it's a slide within a slide. But in essence, the UEC board had agreed 3 key priorities for this year, of which discharge sits in one of them. It was certainly around reducing our length of stay across our system. As we know, our length of stay has crept up over time. And that's linked then to the other 2 priorities around improving category 2 response times for our ambulance colleagues in terms of getting to people in the community. And then a key part of our system work this year is also expanding our virtual wards. So I thought it just helpful to contextualise that this is where the discharge work sits in terms of that reducing overall length of stay. If you go down to the next one for me, Rachel, please, and then perhaps we can come on to a bit of a discussion. So within those 3 priorities, the discharge board, as Mark has just said, has been leading some very specific pieces of work, primarily to try and reduce length of stay, and as Mark said, to get people back home as quickly as possible. And I think the key to the transformation work is a home first principle, which we're adopting at the other end in terms of avoiding admissions where patients don't need to come into hospital. Again, a home first approach is important. But if members of the committee can see, there are a number of programmes of work we've got going on. There's one around Optica, which is around a digital patient tracking system, which again you'll have seen in the slides that Catherine shared. There's a bit around how we're looking to improve overall process, so a piece of process work around flow. There's looking again at our integrated transfer of care approach. There's some process in there, but also again looking at specific things within that integrated transfer of care. A mental health work stream, which is key, obviously, in terms of supporting patients with mental health. And then you can see off to the left, there are then some very specific things that are probably some very short-term pieces of work, which is looking at understanding our overall intermediate care model and doing some particular work around demand and capacity. If you just quickly flick to the last one for me, Rachel. Again, that just gives you, and I won't read through these, but again, Chair, gives you some detail around those particular pieces of work and some of the things that are in there in terms of this 6-month piece of work plus. And then if we don't propose to again go through them, but I'll just pick out a couple of key points in the data. Rachel, if you can go back up to the top for me. So if you look at the 14-day length of stay, you can see this is where our real focus is in terms of how do we bring down our long lengths of stay. And if you look to the right-hand side of that slide, you'll see that broadly we mirror the national position, but obviously our numbers are far higher than we would expect to see. So although the trend is very similar, we're obviously not in a good place in terms of the numbers. So whilst we follow that trend, we've got far more members of the community in hospital over 14 days than we would expect to have, and that's obviously where our biggest opportunity is to improve the lives and the outcomes for patients. But happy to stop there, and I'll do my best to take questions on any specifics, Chair.
Thanks so much, Ross, and thank you for stepping in at the last minute. Do you have any examples where we're seeing some impact, sort of immediate impact from the work you just described?
I think we are. It's very difficult to say whether they're, I guess, natural trends or whether we can see some of the work that we're doing beginning to bite. But I think we have seen some changes in our non-criteria to reside number. So that's it's a subjective measure that we attach, I guess, to discharge, isn't it? Where it's quite difficult to track, but I think we have seen some gains recently in that. And I think, as you'll have seen from some of the data, again, we also are beginning to see some reductions in our overall long lengths of stay. So I think we're beginning to see it bite. Would I be confident enough to say that it's entirely as a result of those programs of work, or whether it is natural trend? Difficult to say at this stage, but it would appear, yes, it is beginning to bite.
Thank you. Paula?
Thank you, Ross, and thank you for standing in at short notice for your colleague. It's really, really helpful for me to say this, and running the risk of sounding like a broken record, the discharge slide, district councils as local housing authorities have got a really key part to play in this, and we don't feature, and I really welcome, and I know my district colleagues will as well. So if that could be taken away, and if you want to come back to me, I can arrange representation, which we won't overshadow everything else that's happening, but should add and complement to get people back home quickly in terms of your first priority. Thank you.
Thank you. But it's all right if I just come back on that quickly, Chair?
Of course it is.
Just to reiterate, I think it's very difficult, isn't it, when you've got a few slides to share with a committee like this. But I think probably what Catherine would say, I'm sure, is that you're already well engaged with the work that we're doing. Perhaps we're not reflecting that work in the slides here particularly. But I know a really key piece of work that's been done just recently is around understanding better the demand and capacity. So have we got the downstream capacity right in terms of matching the demand from hospitals? And how do we then also embed some of those home first principles? So I guess probably there is a bit of assurance and reassurance that you are absolutely engaged and front and centre in some of that work. And we probably are not doing you justice by reflecting that in the slides.
Ross, thanks so much for that reassurance. Would it be possible, please, then to communicate who is representing? Because it's very difficult if people don't know who within their own area of work they need to talk to be able to feed in, then it's very difficult to actually feed in. We had this or similar presentation at the Quality and Safety Committee recently, and I did raise the issue about the voluntary sector. You know, I know is involved, but 3 organizations from the voluntary sector, that is not the sector involvement to me. That is very few free organizations. And I do think, and now that this work program is in its way, but is nothing to stop us to widen that engagement and actually invite more people around the table to help with discharge program. So please, if you can take a message back to the team that we need to revisit again, probably, and re-engage with more people or engage with people who are currently not engaged but are able to support the program, if that's possible.
Of course, thank you.
Judith.
Yeah, my point is kind of very, very heavily related, close to what was just being discussed about the impact further downstream. But the question really was not perhaps so much about involvement of local authorities and voluntary sector, but that's really important. I'm not saying it's not, but is there tracking, or can you reassure us that there is monitoring going on of the impact? You can focus on discharge and you can push to get people out at home, but do we have a way of monitoring what impact that's having on community health services?
Yes, we absolutely can. I think it's I think this is a system issue. So I know you're focusing particularly on discharge today, but as you'd probably expect me to say, it's a systemic problem. So it goes right round to also how do we support people in the community at home? And I think the point you're probably alluding to is that it's the same teams often supporting people to avoid an unnecessary admission as it is those teams that are trying to support them with discharge. So I think as a system, it's very much something that we are alive to in terms of it is the same teams. So some of the work we're doing in other areas of the UEC programme is looking at where those teams are supporting both discharge and, if I can use that term, admissions avoidance, and how do we look to gain, I guess, greater efficiencies through them working much closer with hospital colleagues, things like same-day emergency care, for example. How do we then work further upstream with primary care and PCNs to try and help those teams who often can be spread quite thin? So I think it's absolutely a well-made point in terms of some of our challenges. It's something we are very aware of, and I think we're doing our best to make sure that those teams are able to do and manage both, but where we can, looking at the opportunities to bring those teams together.
Thank you, Ross. Any more questions for us? No, I can't see any other hands up. I think it is important that whatever we're doing is sustainable. We're heading towards the winter and we know what happens in the winter. And I think it would be good for us to get an update again, probably before Christmas, on how we're doing, what is the difference, very importantly, what our residents feel about the improvements we're making. So I will leave it, Mark, for you to think how we look into that. But we cannot wait for another 2 years to see if the difference is made, because we can, there's a program in place. We should be able to start impacting on the problems we've been having for years now. Thank you, Ross. And please, can you say thank you to your team, Mark?
Thank you.
Yes, thanks, Aliona. Thanks, Ross. I think Ross mentioned about the demand and capacity piece. That's the real critical one for us now. It has identified a gap, and I'm hoping when we report back, we'll be able to share some of the schemes, the proposals, the things that we will be happening to try and address that. It won't necessarily solve everything, but around capacity and that we will be looking to bring in. Ross and I talk about this often. Everyone tends to always focus on winter, don't they? But actually, what Ross and I'd like to do is focus on the kind of annual resilience planning, because it's not helpful. To be really honest, when nationally, with very little notice, they say, here's a load of money, go and spend it to make it okay this winter. Well, that's not a particularly helpful way for us to plan for our patients and communities, is it? Hopefully we'll be in an okay spot going to this winter that's coming. Lots of work ongoing.
Thank you, Mark. And I remember us discussing, let's pretend that there is no funding, or let's think there is no funding coming. So whatever is put in place is put in place to be sustainable and viable
Exactly.
as it stands without that additional funding. Yeah. Thanks so much. I don't see any more hands up, Ross, so we'll look forward to further update, but good luck at the next stage in the program. Thank you.
Thank you very much.
Okay, thank you. This takes me now to Community Voices update. If I may invite Shirley and Namrita, and I think Clara and Rob, you're
Yes.
all on call. So over to you, if you can just say who you are and very succinct update, please, if we may. Thank
Okay,
you.
I'll start. I'll do my best, Aliona, to be succinct. Tell me off if I'm not. Okay,
I
so
will.
Rob Jakeman, Head of Integration and Partnerships, but I also have the privilege of co-leading from the ICB point of view, Community Voices with Shelley. I'll let the other team members introduce themselves as they get to their side of things. And this is our third update about the Community Voices programme to this committee. And I think Amrita's just going to put some slides on. There we are. I'm going to start with an overview of the programme, just as a reminder, and some of the outputs delivered to date. Clara's going to talk about a project related to access to research, and then Shelley's going to cover a couple of the new projects we have in the offing, and a summary of some of the challenges and opportunities for the programme. Amrita's going to conclude with some thoughts about next steps, which would appreciate your views on as a committee as to how we proceed from here. So if we go on to this slide here, it's important to pick out this strapline. Our strapline is using your feedback to improve care. And ultimately, that's what this initiative is about. It's fundamentally an engagement tool that adds to those we already have as a system. So this is where I would emphasize that this is essentially a supplementary, hopefully a very positive supplementary activity to those that are already led by the likes of Paul's team and other people associated with that in the community and engagement world. We're an extra string to the bow as such in terms of what we're offering. And we think our USP is the focus on health inequalities in particular. And we aim to listen to public views about barriers and solutions associated with healthcare access via trusted communicators we call community champions, and they try to support people in the moment. So if things actually crop up, they can try and assist them there and then, but also to record any key points via our online recording tool, which we dub the Insight Bank, to help inform decision making by the likes of yourselves and others besides involved in that. And this slide here just seeks to summarize that essentially. If we go on to the next one, please. So expanding on some of those points, it's really worth emphasising our vision here. This is something we've refined since our last visit to this particular committee. So I'm going to read that out because I think this is so pertinent. Norfolk and Waveney Community Voices aims to ensure that people who experience disadvantage because of where they live or who they are can be empowered to understand and act on their health, have a place to share their views, and can help shape how health services are designed and delivered. And we go about that by listening to what people have to say, and we don't guide those in many instances. We'll be directed what people say to us. We're there very much in a listening mode. We will seek to capture the results of what we've gathered so that we can build up a picture of what we're hearing, and that arguably is something that's different in this programme to its predecessors, because really we're able to give this overview of things rather than just a series of anecdotes. And we will try to respond to people in the moment where we can through high quality advice, guidance and information via our community champions. And then there's an intangible aspect there at the end about enabling, which is really about social capital, developing those links between our existing trusted organisations with communities and strengthen them even further still. So that's a sort of output from it. And we go about this, as it says on the right hand side there, through the provision of training and support to our community champions. That's very much being led by our partners, Great Yarmouth Council at the moment in assisting us with that. The development of our Insight Bank, the tool I've mentioned before, so we can really capture what we're hearing. We have a real emphasis on evaluation. We've involved the UEA in evaluating our scheme, and it's something we've built into everything that we do to try and ensure that what we offer is effective. And we link it into our governance arrangements, which I'll come on to in a moment. And crucially, the bit on the bottom right hand side there, we are aware that health issues are affected by a whole range of factors, the full wider determinants of health, and we have open ears to all of those and seek to identify what those are that people are telling us. Go on to the next one, please. So this is just some reassurance about our governance arrangements. In essence, we have a steering group that reports through to Tracy's Health Inequalities Oversight Group, which in turn reports to the Population Health Management and Health Inequalities Board. And we have, and of course to yourselves here, and we have a series of working groups that we've got set up to lead on various matters. There's quite a lot of mechanics involved in delivering a programme such as this. Everything from the insights side of things via Insight Bank, as I say, that's led by Great Yarmouth Council. We've got communication support from Paul's colleagues and others besides. There's a whole load of information governance considerations which we take account of and we work on those. And we have a strong relationship with Norfolk Community Foundation, who are orchestrating things in terms of our arrangements with the voluntary sector organisations, including Aliona's. And we have a series of individual project groups which are linked to the individual projects, which you'll see referenced in a future slide. Go on, please. This is just to give you a sense of scale in terms of the number of organisations and communicators within those that are actually engaged, have gone through our programme of training and support, including the likes of Making Every Contact Count provided by our public health colleagues. The scale of the conversations, as you can see, 1,300 plus. The comment on the bottom left there, I'll leave for Clara to refer to in a moment or two. And the outcomes on the side here are some of the outputs from the in the moment side of things. So the conversations being held, and these are some of the results, ranging from helping somebody access their GP or dentist, or through to housing support, through to accessing community groups. There's a whole wealth of different things, which this slide captures to some extent. Next one, please. And this slide here.
Just summarize it, please. Yeah.
Okay. This is the Insight Bank, a view of it. I'll move on to the next slide. And I'm sure you'll be interested in impact that's delivered via this programme beyond in the moment. If I pick out the top three things there, the Wellness on Wheels bus, the service that's provided, it has been directly influenced by what has been heard through community voices. So it's been responding to that. And we are seeking to shape the talking therapies, sometimes known as IAPT, mental health services. There's a reprocurement of that. And likewise, a community services review underway, and we're informing that through the intelligence we've gathered through community voices. Other information there besides, but I'll move on. And then this just gives you a sense of the generic nature of some of the things that we do through community voices. So we have a core emphasis about listening to whatever it is that people tell us. Then we also have specific initiatives where we will seek to investigate specific things. And that includes access to COVID vaccination, access to research, which is something Clara will talk about in a moment, and other schemes there besides. Those in yellow are in development. Those in dark green have been completed, and the lighter green ones are in progress. So those are the 6 projects kind of within the scope of the programme as it stands. I pass over to Clara at this point.
Thanks, Rob. Hi, everyone. I'm Clara Yates. I'm the Associate Director of Research at the ICB, and I'll very briefly talk to you about our increasing diversity in and access to research. So Community Voices was absolutely integral in enabling us to carry out this piece of work. We worked in Great Yarmouth and Waveney as a diverse coastal community, and it really enabled us to work at pace and speed with our voluntary sector colleagues as well, with Norfolk Community Foundation as a key part of that. We were able to fund and train 11 organisations across Great Yarmouth and Waveney in research, and for them to also have the community voices training, and we collected insights on barriers to research, which are very similar to barriers to accessing healthcare, but still really important for us to feed those into our academics and research teams who are designing projects, so we can get them to address that within their recruitment strategies well ahead of them getting funding for research. It also helped us to increase awareness of research. People thought research was just, I don't know, vaccine studies or something really invasive, rather than it could be completing a survey or taking part in a focus group, and really didn't understand that we wanted to hear their views as well. So it was absolutely brilliant, and we did get people taking part in research as a result of this. We're about to, well, we're hoping that the research training can become an integral part of the Community Voices offer. So for every project that is under the Community Voices banner, they can access this training if they would like to. And we're about to apply for a further £150,000 to expand our approach in engaging with research across the wider Norfolk community. So we will keep going in Great Yarmouth and Waveney, but we'll spread it across the county as well. So I'll pass on to Shelley, I think.
Ready, sorry. We can just skip over these next couple of slides, but it's just to mention that we have a couple more projects which you have information on that we're delivering at the moment. One is around trying to increase access to cancer screening. So we're doing that with our cancer team. And we have another one that we've just literally found out we've been successful around some Core 20 connectors money for a children and young people programme of work looking at her childhood asthma. So it's quite a diverse range of projects, quite versatile as a way of working and as a model, and we think we can deliver a range of strategic priorities through this approach. If you go on to the next slide, please. I'll just pull out a couple of things here in terms of challenges for us and the opportunities that they present at the moment. We are writing, as Tracy mentioned earlier, an ICS health inequality strategy, and we see this way of working because it complements the way that the voluntary sector already deliver and can run alongside the community comms and engagement approaches that we already have in place, but really focus on inequalities as being a tool for a key enabler for us with that health inequalities strategy. We need to get ahead of our planning arrangements and our engagement as a system. We know what our priorities are and we could be proactive with voices. It has been quite reactive at the moment. It's responded to funding opportunities rather than thinking, well, actually, what are our organisational and system priorities and how do we utilise voices to support with those? We need to embed the requirement to utilise voices data into our processes as an organisation. So we look at data in terms of quantitative data when we design our services, when we plan, when we transform. We need to embed the requirement for voices, and that links to the next one really. We don't have it in our gift as a small steering group to influence all the change that's required through the insights that we are generating through the Insight Bank. We do need the system to take responsibility for responding to the insights that are generated. What we're doing is tracking where those insights are being shared so that we can follow up with those individuals that are using them. So for example, we will follow up with the commissioners for talking therapies to understand what changes were made in their planning as a result of the voices data. But we don't have that direct influence. So we do need people to be aware of the voices data, to request that voices data, and for there to be a bit of a push-pull in relation to the information that it has. Capacity and the ongoing sustainable resourcing model for voices is going to be a challenge. We do see it as an income generator. We've got a bid-in pipeline with County Council at the moment for £5 million that we've been working with Clara and the district councils on, as well as other funding streams. So we know it's an income generator, but we do need to have that backbone investment into the model to have it there to build on, and we need capacity and resource. And obviously that we need to assess the impact of the organisational restructure on our ability to deliver this programme and embed it into the mainstream, which is what we really want to do, embed it into our way of working as an organisation. And Amrita's just going to finish us off with a few of the next steps.
Thanks, Shelley. I'm Amrita Kulkarni. I'm the Senior Programme Manager for Community Voices. And as Shelley alluded, some of the next steps that we have within our control right now are delivering against some of the projects that we already have and growing our insights and the impact that we see within the communities. Developing our own approach around community voices and how we build that into a business as usual for the ICB and the alignment of our Core 20 Plus and the health and equalities agenda. I think that the kind of last slide where we wanted to really ask for support from the leadership here is around the non-highlighted aspects of the next steps, which require cross-system working. And it's really to endorse the next steps that we've suggested in our previous slide, and with a mandate for the Community Voices Steering Group really to start developing to integrate community voices across the ICS as a system.
Thank you all. Amrita, that is your last slide, is it?
It is. Yeah.
Yeah. Okay. Thank you. Thank you to all of you. Any questions from the committee or observers? May I ask a couple whilst people are thinking, please? Amrita, I was very pleased to see the recognition of the joint forward plan. So within one of your priorities going forwards, yes, we need to make sure health inequalities will come across all those 8 priorities we have. So we just need to make sure that we have a mechanism of engaging with people and involving them. So making that connection to the joint forward plan is quite important. You cannot be sitting outside it. So pleased to see that. I'm wondering if it would be possible for you to circulate the link to the Inside Bank to the members of this committee. It will be good to actually have a look at what the information tells us, just to inform ourselves. And the last one for me is, I would like to hear, because whilst Rob was talking about the support on the spot, I would like to hear 1 or 2 cases where we actually influenced the way the programs are being delivered based on what people are telling us. Now I've been asking for this for a while now. So I'm wondering, have we got anywhere to demonstrate at least one example where what people said, that's what we did in terms of improvement? Mark, do you want to come on that, or you have another question?
No, well, but actually, you've kind of beaten me to it. I was just going to make the suggestion. So, firstly, I'm really excited about this work. It is a different way of doing things. I know recognise we're at the beginning of this process, but I think I was just going to make the same suggestion. I think that there's the kind of strategic elements, there's the bank element, but I think it would be really helpful to just get 1 or 2, and they can be really small, but case studies together of around, the you said we did, or you said and it's changed because of this, because I think those examples do exist. Thinking some of the cancer work and things of that nature, it would be good to start to share some of that. But I'm a great supporter of this work. I think it's, I talk about it often. I was in an MP meeting recently and was describing talking a little bit about this project, and it's about, and I think what's so key is about hearing that voice that we perhaps haven't had the chance to hear before, and that's what's different here. So that what we do about that is the really critical point, as you said. So sorry, I'm repeating you a bit there, Aliona, but that was my point.
Thank you, Mark. Thank you. Shirley, do you want to
quickly campaign on that one? Yeah, so we've got some quite good case studies now from a short-term outcomes perspective. So really they're derived from the voluntary sector partners that we're working with, those immediate impacts that are happening as a result of the conversations they're having there and then on the ground. Where it's slightly trickier for us at the moment is demonstrating that longer-term system impact of the insights that we're gathering. So Rebecca Champion and Paul's team, for example, shared some of the insights with the Police and Crime Commissioner recently to change or influence the design of their serious violence strategy. Sounds a bit obscure, but there was data in there around antisocial behaviour and community safety that was interesting to them. Now, obviously, that's changing a policy that then is going to take a while to filter down into delivery and implementation, and it's really hard to then track the impact of that. So that's something that we do need to think about and hopefully work with Clara's team around, and indeed any other partner in the system that can support us with that kind of longer term systems impact piece, because some of what we are influencing with this data is policy, strategy, planning, and it's going to take a while for us to see the longer term impact of that change. But we do have some good case studies now on the shorter term impact. So I think we probably need to focus on those for now and put the mechanisms in place to demonstrate the longer term impact further down the line.
That's correct, Shirley. Thank you so much for clarifying that. We also have, for example, talking therapies. You started making a reference to that. We just need to see how that is going to influence what is going to be commissioned going forwards. As an example, we're reviewing the community services again. It will take longer time, but at the same time, all that I'm highlighting is to make sure that what people are telling us is not lost, but is linked to the programs we have, the work streams we have, and is influencing that. So I think it's just if we can put a process for it to happen and for people to recognize that we have this bank of knowledge, bank of feedback people are giving us, we have to say thank you and be very grateful for people finding their time to inform the system as to where the problems are. So the least we can do is to take that into account and put it into our programs of work and then communicate back to the residents as to what we've done different or what we're doing different as a result of it. So I think we just need to make sure we're closing that loop, if that's okay. Thank you. I'll go to Paul and then to Mark and then to Tracy.
Thank you. I'll just make this fairly quick, but it's more or less just kind of really building on the point that Rob, Shelley and Amrita mentioned, which was about resource and really about this taking time to embed. So I think there's a lot of eyes on this work in Norfolk and Waveney, both across the region and nationally. So I went to a national meeting last week on NHS, well, not last week, week before last, on NHS 75, and the national team were quite actually, crikey, is all this actually going on in Norfolk and Waveney? And yes, it is, but I think what we need to do is really kind of bring things back to the fore here, that this is going to be a slow burn, but actually the outcomes of this and the demonstration of listening to people and doing things differently compared to what we've ever done before as a system are the really most important parts to this, I think, from my perspective. So, you know, we've got to remember that actually this is qualitative information, it's gold dust, particularly, you know, when we're talking and listening to some of our most vulnerable people within Norfolk and Waveney and reaching out to those people that we've never really heard from before. It's not a replacement, obviously, for what goes on now, but it's that added, that next layer and that built on advantage. So I think it's, for me, it's just reminding the committee that we're not going to expect quick things from this, but actually it will be slow burn, but the potential outcomes of this could be huge for Norfolk and Waveney to really demonstrate we are listening, we are taking this feedback on board, and this is how it's being used.
Thank you, Paul. I'm glad to hear that. Let's hope that the pace is not that slow, that we don't hear that very soon. So we do need to put some sort of speed into it. But now I completely agree with what you're saying. Mark.
I'll be very quick. As others have said, this was a precursor to the community voices, but I think the approach was very, very similar. As an example, we talked about case studies, talked about examples. We have had in Norfolk and Waveney a very successful vaccination programme. Many of you on this call have been involved in that. I think I had the data last week through to say in the spring campaign, I think we were definitely best in region, not that it's competition, and had the second highest percentage of people vaccinated in you know, compared to all of the other ICBs in the country. So very successful. I believe that a very large reason for that is because of the work we did around inequalities, links to community voices, Rob, and some of the work you did with the Protect Now and things of that nature. So that is an approach that we are building on, you know, work with district councils and many other areas. So even though, you know, we can't say that's a result of community voices, I think the community voices approach is what we're building from, and that is an example of how we can use this information quite quickly to tailor our offer to make sure it is meeting the needs of our population.
Good, thank you, Mark. Tracy.
Yeah, just reflecting and sort of having been involved in many of those programs from the vaccine inequalities work, and before that we had a health equity partnership work that Rob and Shelley were both involved in, and Paula as well. So I think we've learned a lot along the way, and I think this has real potential for the future to really give us the ability to properly engage with our, you know, our population, our communities. I do think there's the element of the insights that we need to overlay with other information, such as what our other colleagues in the system are gathering, our police and crime commissioner, our district council. So it's really rich information to overlay with both other, you know, qualitative data, but other quantitative data as well, to give us a really good picture. I do think it's really important that we, as a consequence of what we're hearing, we have a means to kind of generally feed that back to the population to say, look, this is what we're hearing, this is what we're doing as a result of that. But I also think there's, to me, the kind of joy just thinking, I'm reflecting on the plus paper I just presented to you, that certainly when we've got key communities that we know absolutely have huge and multiple disadvantages and really struggle, we can do some real targeted work, I think, with this approach, which is where we get some real benefits, I think, from. So certainly thinking about those plus communities. And I think you can't underestimate that kind of contact of having somebody that's there, you trust, that's not judging you, and just having that engagement and supporting you to access care and make choices, you know, in life that hopefully will improve your health outcomes.
Yeah, can't agree more, Tracy. And yes, conflict of interest for me, but we started delivering this before I got involved with the ICB. As a delivery partner, I do know the benefit. I do understand the, you know, how the system can benefit, and most importantly, how the residents can benefit from telling us of what the experience is, and for us to do something about it. So all this is very good, and I'm complete support of the community voices, and I do hope that we will get it embedded into the way we take the the work forwards and within the structure and within all our programs. So yeah, I would like to thank the team for the work done to date with it, and to encourage the executive team to just consider making sure that this is embedded as business as usual going forwards, and get the support. So that would be my take on it. Any other questions? No, I can't see any. So thank you again to all of you. Thank you for your presentations, and we'll look forward to see how it goes. Yeah, I'll definitely look forward to big interest to see what difference we are making in terms of impacting the provision going forwards, all our provision. Thank you so much. So I will move on now to the last item on our agenda, if that's okay. With Paul, People and Communities update, Paul, please. You have the whole of less than 10 minutes.
Thank you, Aliona. I did have quite an update to give today, but what I'm going to do is I'm just going to focus on one thing, and then I'm going to share a written update with this committee. And we'll also, because it is a meeting in public, I'll post a summary on our website as well for continuity. The thing that I'm going to focus on today is just, it relates to one of the actions from the action log, and that is in relation to the lived experience representation on this committee. Yep. So this is something that obviously we've been talking about as a committee for some time, but quite rightly, we've got to get it right, because what we don't want to do is run away and go straight to recruit, select. I keep saying the word recruit. We're not recruiting, we are selecting representatives for the committee, but we need to do it right, and we've got to have the relevant support mechanisms in place to make sure that if people do give up their time, to be able to regularly support the committee and provide this independent support to the committee from a patient and community's perspective. We need to compensate them for doing so, but being able to compensate them in a way that doesn't affect their, for example, benefit entitlement. So what we are doing very closely with our finance team behind the scenes is we are continuing to liaise with HMRC in relation to making sure that the ICB has a policy in place that will basically make sure that when we do go out to receive expressions of interest from people of all walks of life across Norfolk and Waveney, that they can come forward and provide that support, provide those crucial voices from the people that we need to hear from. So what we don't want to do is actually go straight out now. The lived experience pack is ready. But if we go straight out now, we're going to be going out without the confirmation that we're going to be able to get to the right people and enable the right people to provide that support without having an impact on their personal welfare and their personal benefits. So I am hoping and absolutely crossing fingers that within the next few weeks we should get some clarity on this from HMRC. We have got a link in with HMRC now. Our finance team are proactively having conversations to get this sorted. But I think from my perspective, and obviously would really value comments from committee members, if we're going to do this and we're going to do it right, we've got to get the process right to make sure that people can come to the committee, and the people that do come to the committee are the people that we absolutely need to be there. So it's not about just going out there randomly selecting people. We've got to really put it out there so that everybody can come forward to make sure that the committee is supported by people from all walks of life, from all different groups. So I hope that's a fairly clear update. Just to provide reassurance, we are working at this at pace behind the scenes, but I do anticipate definitely well before the next meeting, we should be out there actively recruiting these individuals to provide that support to this committee.
Thank you, Paul. Thank you for the update. I know it hasn't been an easy journey, and not because there was no trying. Is getting the right people to speak to the right people in HMRC was one of the biggest challenge. We do have a provisional policy in place on recognition, and Cassie, remind me what the full policy is called. is compensation for participation. What it recognition in something policy,
Yeah.
don't we? Yeah.
Yeah, we do. Yeah, I'd have to look
so-
back at them. I'd have to look back at the meeting to try and remember.
Apologies, I can't remember the exact
Yeah,
title
sorry,
of
I
the
can't.
policy, but we have an interim policy in place.
Yeah,
But the
I'll
finance team
I'll
is
find it and put it in chat.
very kind. Thank you. It is just making sure that we do not compromise people's wealth, benefits. And we want to, as Paul is saying, we want to hear from many people, not just those who are already active. And that's one of, for me, was a big objective. Let's not go for those who are already engaged. We need to reach those who do not currently engage. And that is taking longer time because of this financial thing, which needs sorting out properly. So Paul will please put the pressure. I'll continue putting the pressure too, but we just need to make sure we get there sooner rather than later. It has been. We hope to have somebody for today in position, or few people, because we don't have a cap, do we? But we're clearly not there, so we need to push with it.
Absolutely, Aliona. It's a really important priority for this committee, and really important that we get those voices. So it's something that's high on my radar.
Thank you. Any questions for Paul, please, from anybody? Thank you so much, Kathy. Participation, rewards, and recognition policy. Rachel, that should be easier for the minutes, please. Thank you. Thank you. Okay. Paul, no questions raised. And yes, we'll look forward to the written update afterwards. If that can be circulated, please, will be great. Thank you so much for that. Any other business from the committee members? No. Okay, well, I didn't receive anything in advance. So what it leaves me to say is a big thank you to you all. Thank you for your contributions. Thank you to all the presenters. A good work. We're getting there with the scrutiny. We need to start seeing now solid examples and seeing the impact and making sure that we are actually addressing the needs of our local residents. So, hang on. Do you want to ask a question now?
Yeah.
Yes,
so,
please do.
Do you have any sort of representative from the community that tend to come to this forum or this meeting? And if not, is it something that you should consider?
Yes, so that is what the recruitment we just talked about,
right, okay.
because people get paid to take part, and we need to be careful how we pay because it'll affect their benefits.
Yeah. Okay.
So that's the delay is caused by the HMRC and finance type stuff.
Okay. Right.
But now, definitely, we initially thought we'll have two representatives, but we decided not to have just two because the spectrum of issues people are facing is very wide. So we didn't put a cap, and we'll go to open recruitment as soon as the financial arrangements are in place, because that is the stumbling block at the moment. So we'll keep our fingers crossed that we can move that forward as soon as possible. Otherwise, yes, thank you again to all of you. Thank you for your contributions. Next meeting is on the 25th of September on Teams, and I'll look forward to seeing you then. In the meantime, please have a good holiday if you are taking annual leave, and stay safe, and all the best to you all. Thank you.
Thank you for having me.
Thanks.
Thank
you.
you.
Bye-bye.
Thank you. Bye-bye.
Bye-bye. Bye-bye.
Thank you.